Alrighty. Good evening, everyone, and welcome to Healthy Dose, your health and care conversations. We are so incredibly excited to welcome you this evening to the second edition of the Healthy Dose. We had our first one last month, and we're really excited to be continuing in the maternity topic in this month. And tonight, we're going to be focusing specifically on couples experiencing infertility. I will be hosting tonight. I'm Dr. Peter Kiwana, Clinician Engagement and Patient Experience Manager at Netcare, and the talk will be ran by Dr. Jack Biko, who is here to answer your questions. So just a little bit about Healthy Dose. These virtual events are created for you to be able to engage with clinicians from the comfort of your home. Every month, we feature a specific topic, and then our doctors are very kind enough to take time out of their day to come here, present on the topic, and also answer some questions. Please note, very importantly, that any information shared on this platform does not constitute medical advice and that you must contact your medical professional if you have any concerns. We also ask that everyone stay on mute and keep their cameras off just to ensure that the stream quality remains good. Tonight, we are joined by Dr. Jack Biko. Dr. Jack Biko is an experienced obstetrician gynecologist and fertility specialist who practices from Netcare Femina Hospital. Welcome, Dr. Biko. Thank you so much for joining us tonight. We really appreciate you taking your time to share your knowledge and your insights and really to share with us on a very interesting and hotly debated topic that we know raises a lot of questions and a lot of concerns for people all over the country. So I'm just going to give Dr. Biko a moment to just get on camera with us.
Good evening, Dr. Kewa.
There we go. Yes. So thank you so much, Dr. Biko. Thank you for joining us tonight. So I'm going to hand over to Dr. Biko, who's just going to give us a little bit of a summary about the work that he does, and then he's going to be launching into the presentation that he's prepared for us around couples fertility. Thank you, Dr. Biko.
Thank you very much. Thank you, Doc, and the Netcare team for inviting us to this session. These are very important educational sessions, not only for doctors, but also for our patients. We know that infertility is a major problem. It's a big problem, but we also know that it is not funded by most medical societies. So I'm a board member of SASREC, which is the Fertility Society of Southern Africa. We are engaging with many medical societies to try to encourage them to reimburse our patients with infertility, because according to the WHO, infertility is a disease, just like flu, just like TB, just like hypertension. Yet they pay for all other diseases except for infertility, and we think that is unfair. So if I can start my presentation.
We can see your slides, but it's not yet in presentation mode.
Okay. Is that all right?
Okay, now it's perfect. Yes, thank you.
All right, ladies and gentlemen, we're going to talk about the couple with infertility. We are going to be very general, not very specific, because we've got different doctors who will advise you differently, but these are the general aspects of the couple with infertility. We talk about barrenness amid plenty in Africa, because in Africa, we have high rates of fertility and very high rates of infertility. In our continent, those patients who have children have a lot of children, 5, 6, 7 children. And therefore, if you are infertile in a situation whereby everybody else has got a lot of children, you become non-significant. In this continent, we have high rates of secondary infertility, mainly due to tubal infections, fibroids. We know that fibroids tend to be genetic, and that African patients tend to have fibroids earlier. Those fibroids tend to be bigger, to grow faster, and to recur quicker. And then there's also a lot of environmental changes, which we spoke about last week. In fact, the infertility belt of the world is right through Southern Africa, Central Africa, and West Africa. So the highest rates of fertility in the world are in Africa, and the highest rates of infertility are also in Africa. Causes of infertility is the same between men and female, exactly the same. So according to the WHO, 1 in every 4 couples in the developing world, in our part of the world, has issues with infertility. That's a high number of couples. We should know about that. We also know that infertility is not an individual thing, it's a couple thing. It takes 2 to tango. We cannot say, no, it's my husband's problem, it's my partner's problem, or it's my wife's tubes or whatever. It doesn't work like that. It is a couple problem. We are both in it together. And when we manage it, we manage the couple, not the individual. So I want to quickly do about the male aspect and spend more time on the female. Now, one of the tests that we do to determine where is the problem when we do infertility workup is a sperm test, the semen analysis. It is very, very important to understand that a semen analysis is not a measure of manhood or a measure of your potency. In fact, an abnormal semen analysis is not an indicator that you will not have children in the future. It's not an indicator also that you're going to struggle to fall pregnant. In fact, we can see from the data there that 52% of men with subnormal sperm parameters will achieve a pregnancy within 3 years. We also know that many men with normal sperm parameters, will not achieve a pregnancy until we do something else like IVF or insemination or something like that. So sperm analysis it's not an absolute test, it's not an absolute value that can define a man. Now, what is infertility? We agree that infertility is failure to achieve a pregnancy within 12 months of regular unprotected intercourse. So if the husband's worked in another town and the wife is somewhere else at home and they don't meet regularly, it will take more than 12 months to conceive. So it's 12 months of regular unprotected intercourse. But we don't want our patients to wait for 12 months. If you're 35 years and above, please don't wait for 35 for 12 months. See your doctor within 6 months. If you struggle, go within 6 months, see the doctor, because age is not on our side. And those patients who have been diagnosed with a particular condition, whether it's endometriosis, polycystic ovaries, or other medical conditions, if you struggle to fall pregnant, don't wait 12 months, don't wait 6 months, go to the doctor immediately. All patients who are 40 years and above shouldn't waste time. They should go to the doctor immediately. Where there is previous surgery to the scrotum or abdomen in men, we also recommend that they see the doctor immediately. Don't waste time by waiting 6 months or 12 months. Let me just get this out of my way here. As you can see that in normal couples, where everything is fine, 84% of patients will conceive within 1 year of regular unprotected intercourse. And 92% of patients will conceive after 2 years, and 93% will conceive after 3 years. So the human reproductive system is the most inefficient system in the body. That's why it takes so long for us to fall pregnant. We've got a very, very inefficient reproductive system. The human eggs are very fragile, very sensitive, and the human sperms have their own issues. So we really struggle to get our patients pregnant. And because of all these challenges, the egg challenges, the sperm challenges, and the inefficient reproductive system, we have what we call the pregnancy loss iceberg. Out of every 100 patients who fall pregnant, naturally, there will be 30 babies born. Out of every 100 patients who fall pregnant through IVF, there will be 25 babies born. That is just how it is. We cannot improve on that. What we do know is that 60% of the patients will have subclinical pregnancy losses. In other words, 30% of the patients will lose their pregnancy before the embryo attaches to the womb. Another 30% of pregnancies will be lost after attachment of the embryo on the womb. So the patient will not even know that they were pregnant. So 60% of our patients who fell pregnant will lose their pregnancies before they even know that they are pregnant. And that is because we've got such an inefficient system, reproductive system as human beings. And only 10 to 15% of our patients will lose their pregnancy after they already know that they are pregnant. Now, everybody can see they are pregnant and then they get a miscarriage. That's a low number. The majority of patients would have lost their pregnancies way, way before they even knew that they were pregnant. Now, what are the common factors of infertility? There are female factors and then there are male factors. There's ovulation issues. There's the wrong timing of ovulation. There are problems in the fallopian tubes, problems in the ovaries, problems in the uterus, problems in the mouth of the womb, which is called the cervix, and then there's the peritoneal diseases, things like the commonest would be endometriosis that we see pretty much frequently. And then there are male factors which can contribute to infertility. This include when the guys do not produce any sperms, there's no sperm production, or the sperms are not delivered because the tubes are blocked, or the sperms are there but they are abnormal, or the sperms are delivered to the wrong side. Now remember, men have got lots of tubes and there's a lot of connections between the tubes. Sometimes the sperms take the wrong route and end up in the bladder instead of going outside. And sometimes we got infertility because there is sexual dysfunction such as libido. So there are many causes why we've got infertility. So one of the commonest causes is blocked fallopian tubes. All right. Now, what causes blocked fallopian tubes? Previous infections, pelvic infections, vaginal infections. Those things can cause blocked fallopian tubes. Previous surgery, like ectopic pregnancy, yes, like appendicitis surgery, all those things can cause blocked fallopian tubes. Endometriosis is a common cause of blocked fallopian tubes. And about 20% of the patients who sterilize, between 20 and 30% of the patients who sterilize will regret their decisions to sterilize. Many of them, because it's a new partner. Some of them just regret, not because it's a new partner. I recently had to reverse a tube of a patient who's a psychologist because she wasn't psychologically well because she sterilized. So we had to reverse the tube, not because she wanted to fall pregnant, because it was a psychological issue. Blocked tubes are serious problems. If you look at the picture on the right there, we can see that the normal fallopian tube has got fimbria, finger-like structures. Those finger-like structures are supposed to pick up the egg from the ovary so that the egg can be in the fallopian tube where it gets fertilized. Now, if the fallopian tube is blocked, those finger-like structures are damaged and the egg cannot be picked up. And therefore, the patient doesn't have an egg in the fallopian tube, which is the place where normal fertilization takes place. A blocked fallopian tube gets full of water, and that water contains toxic substances. Those toxic substances can also be harmful to a baby when the patient conceives. That's why your doctor will tell you that your tubes are blocked. We have to open them or take them out or fix them. Now, one of the commonest causes of blocked fallopian tube is endometriosis. Now, endometriosis has got a lot of reasons why it causes infertility. It damages your tubes, it blocks your tubes. It messes up the lining of the womb by increasing the amount of inflammation in the womb. And it also interferes with the interaction of the sperms and the eggs. So the sperm and the eggs come together, but they cannot interact appropriately because of the presence of endometriosis. So endometriosis is a problem that needs to be resolved to help patients to fall pregnant. So as we can see, the mild endometriosis causes infertility because it impairs the interaction between the sperms and the eggs and also interferes with the implantation of the embryo. Severe endometriosis moves the fallopian tubes away from the ovary. It damages those finger-like structures of the fallopian tube. So you get failure of the pickup of the eggs by the fallopian tubes. And in these cases, the patients will not fall pregnant naturally. They will need assistance. And evidence has shown that if you've got stage 3, stage 4 endometriosis, and you do IVF, you've got a good chance of falling pregnant. Or if you do appropriate surgery at an appropriate center, also a very good chance of falling pregnant. We can discuss the options of between surgery and IVF. But stage 3, stage 4 endometriosis, normal intercourse will not work. Insemination will not work. It has to be IVF or it has to be surgery, appropriate surgery. Now, there is currently a problem with the diagnosis of endometriosis. We know that patients and doctors think that to diagnose endometriosis, you must do surgery. This is the old understanding where laparoscopy was essential to make a diagnosis of endometriosis. The current thinking is that if a patient's history and clinical symptoms suggest that you got endometriosis, you have endometriosis. There is no need for an operation to make a diagnosis of endometriosis. If everything suggests you have it, we treat you for endometriosis. Right, the next thing, and it's a big thing which causes infertility, is dysfunctional ovulation, where the patients do not ovulate appropriately. Now, two common causes of dysfunctional ovulation is polycystic ovary syndrome, which is a common syndrome affecting about 1 in 10 patients. And secondly, brain problems like a tumor in the brain, severe exercise, excessive stress, and those patients with nutritional issues like anorexia nervosa. If you've got one of those problems, we tend to struggle to fall pregnant. And it's important that patients with, especially PCOS, that they see a fertility specialist, because the average GP will struggle to get you pregnant, and the average gynecologist will also struggle to manage a patient with polycystic ovarian syndrome, because we have to stimulate you in a particular way to grow the follicles. Remember, patients with PCOS have a lot of follicles, got a lot of eggs, but those eggs have to grow in size to about 20 millimeters to ovulate. Now, patients with PCOS, the eggs don't grow. It's like the eggs are lazy. They are there, but they are lazy to grow. So we have to help you to grow those eggs, and we have to monitor the growth of those eggs, because if we don't monitor the growth of those eggs, we might find out we grew 10 or 20 eggs, and to just say go have time intercourse can be very, very dangerous for patients. So PCOS patients have to be managed in an appropriate center, which is a fertility clinic. All right, we see a lot of patients with PCOS and with ovarian cysts who had surgery from the GP or the general gynecologist. Please remember this, in general, surgery for cysts is generally a bad idea. In general, cyst surgery will damage your ovarian reserve, which is how much eggs you have, because women are born with a fixed number of eggs. As they get older, that quantity as well as the quality of the eggs will decline and decline and decline and decline. Every surgery we do on the ovary and on the pelvis will reduce the amount of eggs any further. So in those patients with PCOS, not all of them will benefit from ovarian drilling. Very few group of patients will benefit from ovarian drilling. And there's a specific way in which ovarian drilling is done. The picture you see there on the right, it is a common way in which ovarian drilling is done, and it is a wrong way in which ovarian drilling is done, because those many holes in the ovaries will damage the ovarian reserve. So that's why we say that our patients, when they do require any treatment for PCOS, it is better that you go to a fertility center, because we have the guidelines as to how we should manage this particular condition. We can talk about it more in the Q&A if necessary. A big problem that we see is the patients waiting for Mr. Right. And unfortunately, many of our Christians or born-again Christians fall in this category. They waiting, the Lord hasn't brought the right man yet. And they wait, and they wait, and they wait. My oldest patient waited for 54 years, and she got the right man at the age of 54 years. We managed to get her pregnant with donor eggs. Now, ladies and gentlemen, as you get older, the quality and the quantity of the eggs will decline. 18.5% of the cycles, IVF cycles in South Africa in 2014 were egg donation cycles. Because once you reach there, if you look at the figures there, at the age of 43, 80% of the eggs of your eggs are abnormal. 80% of the eggs of a 43-year-old lady are abnormal. Abnormal eggs make abnormal embryos. The womb has a biological sensor. It can pick up if this baby is normal or abnormal. Now, if the womb picks up that this baby is abnormal, the womb is going to reject that baby. Now, if the womb rejects the baby, we call that a miscarriage. So the womb will reject abnormal babies. Every now and then, the womb fails in rejecting abnormal babies. And then we get delivery of babies who are born abnormal because the womb has failed to recognize them. So aging is one thing as doctors we cannot change. I know there's a lot of patients taking various medications, various therapies to try to improve the air quality. The truth of the matter is, at this moment, there is nothing we can do to improve the air quality of a patient who is aging. If you get older, unfortunately, you might have to use donor eggs or go the adoption route. At the age of 45, almost all the eggs are abnormal. And the patients will insist that, doc, please use my eggs. Please try at least once to use my eggs. We understand because there's also psychological issues here because somebody must feel that I've tried my best before I use donor eggs. So we sometimes agree and say, okay, you are 45 years old. We don't think you should use your own eggs, but you really want to try. Say, okay, we'll do a low dose stimulation, get 1 or 2 eggs, try our best. If you're one of the 1% that works, great, but we don't expect the best outcome from you. So aging is a big problem in our society. All right, like I said, as you get older, fertility rate is low and the miscarriage rate is high. So 80% won't fall pregnant. The 20% that do fall pregnant, 80% of them will miscarry because the baby's abnormal. Now, the uterus is also a major problem that can cause fertility issue. There are fibroids, there are polyps, there are scars. Scars are a big problem. And I know of patients who go to their gynae and their GPs every year to clean the womb. It's very bad, guys. DNC is the worst thing you can do in your life. We hate DNC because it causes scarring of the wombs, and scarring of the womb is extremely difficult to treat. And there's something called an eosinoceal, which is cesarean section scar defect. You cannot control that. It can cause problems in the womb. And then there's various uterine abnormality. The majority of abnormal uteri don't require treatment, so we don't have to bother about that. Fibroids are the commonest problems that we see in our patients. Fibroids can impair fertility. Fibroids do cause miscarriages. Fibroids can cause heavy menstrual bleeding. But it is important to know that treatment of fibroids does not always enhance fertility. Sometimes it may worsen fertility if it's done incorrectly. 1 in 3 African patients have fibroids, but not all patients require treatment because they have fibroids. We only treat certain fibroids. Not all fibroids will require treatment. So, like I said, most fibroids do not affect fertility. Removal of these fibroids do not increase pregnancy. So don't just remove fibroid because it's there. I'm going to rush the slide over because we don't have time. Now, there's a concept called fertility preservation where we have to preserve our fertility. The objective of fertility preservation is to preserve your reproductive health. And it can be considered when future fertility may be compromised. For instance, a patient has been diagnosed with cancer. We can take your ovaries or take your eggs and put them away before chemotherapy. And in those patients where there's a family history of getting early menopause, premature ovarian dysfunction, we can also take your ovaries and put your eggs and put them away. Patients with severe endometriosis, we know that endometriosis will damage your ovaries. We also know that surgery to endometriosis will also damage your ovaries. So it might be a good idea to take the eggs of patients with endometriosis and put them away, preserve those eggs. And we also, those patients who want to undergo transgender surgery, we prefer to freeze their gonads before they undergo surgery. And then there are those patients who are not ill, but are not in a relationship and want to preserve their fertility. It's referred to as deferred reproduction or social fertility preservation. We often talk about free your career or freeze your eggs to free your career. You want to go up in your career, don't want to rush into marriage, so we can freeze your eggs so that in the meantime, you don't have to worry about getting older. You can push your career, and then once you're ready, once you're 45 or whatever, you can come back. Your eggs are still 30, 35 years old. So it's an option that we see a lot with our junior doctors these days. So the available options to freeze your fertility, we can do egg freezing, we can do sperm freezing, we can do embryo freezing, ovarian tissue freezing, and testicular tissue freezing can also be done. So now my personal recommendation for those patients who want to freeze their reproduction, whether we should freeze eggs or embryos, I always recommend that even in a married couple, that we freeze the eggs and the sperm separately and make the babies as necessary. Because if we freeze the embryos, if I make the babies and freeze them, and the couple breaks up, then we're in trouble. Because none of them can use them without the other one's permission. Causes severe, serious legal issues. So from our point of view, we always recommend that let's separate them separately, even if you're married, and then we make babies as necessary, but we keep them separately. Should you divorce or something happen, you take your eggs, you take your sperms, and everybody goes home. Everybody's happy. All right, now the treatment options, once you've been diagnosed with a reproductive issue, there's timed intercourse, there's intrauterine insemination using your partner's sperms or donor sperms. And then there's IVF, there are various types of IVF, natural cycle, modified natural cycle, minimal stimulation, the standard IVF. There's ICSI for male factor infertility. And those don't have eggs, like the 45 years old, we can use donor eggs. And then there's a concept of surrogacy when necessary, which is a legal issue. And the IVF process, you have to undergo its consultation, you get examined, you get psychological counseling, which is very, very important. And then you get treatment to stimulate egg production. Eggs are retrieved, and then they get fertilized in the laboratory. And then if necessary, we can do pre-implantation genetic testing before we put the baby back in the womb, so that we can know exactly if the baby is genetically okay or if there are problems with the baby before we put them back in the mother's womb. And the excess embryos can be frozen for future use. So we know the data in South Africa. We know what's happening in South Africa. I'm going to give you the 2014 data from our society, SASRAC, which is the Fertility Society of South Africa. In 2014, we had 52 million people in South Africa. We know that 10% of our patients will require IVF services. All right. But we only did about 5,000 IVFs in 2014, which means that only 6% of patients who require our services in South Africa got our services. Only 6%. That's not nice. We got a registry whereby all the clinics that are accredited to SASRAC send all their data to, because we want to know what's happening in our country. So we track and monitor IVF activity in South African clinics which are accredited with SASRAC. And the outcome, and we compare it to international standard, you can see that the pregnancy rate in South Africa per aspiration was 33%. In the USA was 37%, which is pretty much similar. The pregnancy rate per embryo transfer was 39%, 40% in South Africa, and 45% in the USA. Live birth rate, we were 16%, and in the USA was 30%. So we compare our results to international practice and see where we stand and improve where we have to improve. That's why, ladies and gentlemen, if you're going to do IVF, if you require IVF, please ensure that you do your IVF cycle in a SASREC recognized center of excellence, because we know the data of the clinic, we know the outcome of the clinic, we know the results of the clinic. Thank you very much.
Thank you so much, Dr. Biko. That was such an informative presentation. There's actually a lot of questions that have come through already, and I think some of them you've spoken to, but it would be nice to sort of delve a little bit back into them. So one of the questions is coming back into the causes of infertility, and that was really around, can stress and as its own be a driver of infertility?
Yeah, so stress is one of those brain causes of infertility, the hypothalamic causes of infertility. So the brain sends messages to the ovary to produce eggs. So if you are stressed, those messages are not sent to the ovary. And if the ovary doesn't receive those messages, then the patients can become amenorrheic. They don't have periods because the brain is not sending information to the ovary, and the ovary responds to the brain. If there's nothing coming from the brain, it doesn't respond. No response, no menstruation, no menstruation, no pregnancy.
Okay, all righty. Thank you so much, Dr. Biko. Another question that is quite interesting is around male fertility. And the question is around what can improve male fertility? You mentioned in your earlier slides that male fertility has gone down quite significantly. And so the question is around for men, are there things that they can do to improve their fertility?
Yeah, so we know that there are a number of factors which can affect the sperm parameters of men. Shows a lot of things. One of the common things is, like we spoke about last week, it's environmental factors. Something called endocrine disrupting chemicals that can impair the sperm quality and the sperm quality. We also spoke about the decline in sperm parameters over the last 50 to 70 years, to the extent that in 2024, we are very happy if I see in a man's semen analysis that 5% of the sperms are normal. We are very happy. You can imagine if you say that we complain about a matric pass rate of 40%, but we are happy with a men's sperm count of 5%, morphology of 5%. So it so shows you that values have come down quite significantly. But there's still medication which, when taken for a short period of time, will help with those parameters. And there's still medication which will destroy the sperm parameters. For instance, men who take steroids, exogenous steroids, they will kill their sperm counts, because those things will destroy them completely. And then there are certain supplements like sperm aid, Prelox. They are okay if you take them for 3 months, but not more than 6 months. If you take them for more than 6 months, you're going to mess up the sperms again. So there has to be control in what we do. Too much of a good thing is also bad, because you move from oxidative stress to reductive stress. So it is better for male, better that they see the doctor, then we can channel them exactly what we should do for them. It's very important.
Okay, thank you for that, Dr. Biko. Another question is around, so you spoke about couples infertility, and you spoke around, the time that a person should sort of wait before they come to see the doctor. Because I think sometimes what happens, people think very early on that they have an issue and they come after 1 month, but you mentioned coming after 6 months for couples over 35, and perhaps after 12 months for couples who are younger than that. One of the follow-up questions around, when it comes to trying, like what constitutes a trying? How often should couples be copulating for them to say that they have tried hard enough? Is it a daily thing? Is it a once a week thing? Because I think you sort of touched on it a little bit earlier, but if you could just give a little bit more insight.
All right, so the half-life, the amount of time the sperms can spend in the fallopian tubes is 72 hours. So which means that a couple will be okay to have intercourse once every 3 or so days. Not every day. Every day it's a bit of an issue, going to be difficult. So maybe once every 3 days would be regarded as adequate. And the other problem that we sometimes do as doctors, we have something called timed intercourse. It can be very stressful to tell the couple that you need to have intercourse tomorrow. That is very stressful for a man. So rather, if you say every 3 days, whenever you can, that should be pretty much adequate as regular intercourse, unprotected intercourse.
Okay. Thank you for that. There's another question here around embryos. And the question here is around if an embryo is not implanted, right? Is there any way, or if an embryo stops developing in the lab, is there any way to know if that embryo did not develop because it wasn't going to be a successful pregnancy? Or, is it kind of like if it doesn't develop in the lab, then you can assume that it wasn't going to develop in the uterus?
Yeah, so in the past, we used to transfer embryos on the 3rd day.
Mm-hmm.
Now we transfer them on day number 5 or day number 6. And the pregnancy rate during the 3rd day was very low. And now it's it's much higher than it was when we did during day number 3. What we do know is that many embryos will grow well up to day number 2, day number 3, and then they will drop. The growth will start going down, some will die. Now, if you transfer them on day number 3, I'm transferring embryos that will potentially die, and I'm giving you all the hope that things are going to go well. So a day 5 transfer means that I'm putting an embryo with a good chance of developing. So embryos can die post day 3 because it happens all the time.
Okay. Now I hear you. And then there's another question that keeps coming up a lot, and it came up even in the pre-questions that people asked. And there's a lot of concern around age. So one of the questions specifically sort of around the ages of 45 and upwards, is it a case of if you are trying to conceive at 45 and upwards, you should see a fertility specialist immediately? Is there any hope for women who are 45 and upwards to conceive naturally?
If you're 45 and above, listen, you get that 1% of people will maybe with luck and fall pregnant. But if you're 45 years, if you're 40 years and above, really, you have to go to a fertility clinic because the chances of falling pregnant above the age of 40 are extremely low. And there is no time in wasting. You can't waste time because often the patients go to the GP and they get given Clomid, the tubes get tested and all that kind of stuff. And there are guidelines, there are studies which have shown that in patients above the age of 38, it is better to go straight to IVF instead of wasting time doing all other stuff. So we don't want to waste time because time is of the essence here. So if you're above the age of 30, ideally, you must go to fertility clinic.
Okay. No, that's very important. Another question has been asked around, is artificial insemination or IVF an option if a person's tubes are tied?
So artificial insemination means that we take the sperms, we put them in the womb. But the fallopian tubes have to be open because the sperms have to move into the fallopian tubes and the egg has to go into the fallopian tube to make the baby there. But the egg cannot go into the fallopian tube because the tubes are blocked. Therefore, artificial insemination is inappropriate in a patient who had tied tubes before. If your tubes are tied, you've got 2 options: do surgery to reverse them or do IVF.
Okay, all right. And then another question, I think there's a lot of sort of interest around what is actually affecting fertility. So one of the questions around smoking, and does it affect fertility if one partner smokes or if both partners smoke? Is there a difference if it's just one partner versus both partners?
Yeah, so smoking is that effects on the male and on the female.
Okay.
The female, it messes up your fallopian tubes, the movement, the sperms have to move to the eggs have to move to the sperms. So that movement, there's this little hair-like structures in the fallopian tube that are impeded. So the movement is messed up in patients who are smoking. Therefore, the chance of falling pregnant is much lower. And also the risk of getting an ectopic pregnancy is higher in smokers versus non-smokers. So lifestyle factors have got a negative, some lifestyle factors do have a negative effect on both male and female infertility. So smoking is not good for fertility. It's also not good for pregnancy because if you smoke, the baby's also smoking.
Yeah, no. That's very important. And a very interesting question here. So we've spoken quite a bit during the session around preserving fertility. And there's a question around how much does it actually cost?
So it depends what is it for. So in our society, if we have to preserve fertility because you've been diagnosed with cancer, we have agreed that the clinic will charge you cost. Nothing more. Because this is an emergency. This is something which is totally unplanned. You've got cancer, we must do it quickly, random start, and then we charge you simply the cost. No, we don't make money from that. In social freezing, it is like any other IVF that you're going to pay. And the cost depends on where you are. Remember, the clinics don't charge the same amount of money. Our fees depend on where we are. We have to pay rental rates are different in various centers. The facilities in the various clinics are different. The staff is different. So it'll depend in which area you are. But in average, it ranges between 70,000 and 120,000.
And is there any medical aids that assist patients with this?
Yes, SASRAC and IFASA, which is a patient support group, we had meetings with Discovery, and we managed to convince them to pay for IVF. They pay 75% of the total cost of IVF for patients in certain classes of their scheme. Other medical aids are also coming on board, and many of them are not yet on board. So we're getting more and more data so that we can convince all the medical aids to come on board, because that will help us a lot if they can do that. And we have to be grateful to IFAS in particular, because they went all out of their way. It's a patient group that went out and spoke to Discovery as well. We work with them to make sure that our patients get a good deal from the medical aids.
No, that's very, very important. Another question here around male sterilization. So we spoke a little bit about, you touched on female sterilization and how potentially, partners can regret it later on. But what about men who do vasectomies very early on? Are there any sort of counseling that they're given, and how reversible is that procedure?
You know what? It is more difficult to reverse male sterilization than to take out the sperms with a needle, put the needle into the testes and pull it out. That's it. 1 minute, 2 minutes, it's done. It's not like the women. So it's in men, it's probably better to just put in a needle and take out the sperms than to reverse the sterilization, because it's quite a microscopic procedure to reverse sterilization, unlike in women. So men, I would recommend the surgery to remove the testes by aspiration or whatever, because men have been sterilized, they still have a lot of sperm that we can access easily. The testes are outside, no deal, no big deal. We can do that much easier.
Okay. So I'm going to go to some of the questions that were asked early on in the session, but please feel free to continue to ask questions in the chat. So prior to the session, we asked people to submit if they had any questions for the doctor, things that they would like to ask. So some of the questions are around, for a patient who's been on contraceptive, whether it is the injectable contraceptive, the oral contraceptive, how long after they have completed or stopped that contraceptive should they wait before they sort of fall pregnant?
So once your periods are normal, you can start conceiving. Usually normal periods indicate that you got ovulatory cycles. So in general, with the oral contraceptive pills, usually a month later, you should be okay. With the injection, it can take a bit longer, 3 to 6 months, for your periods to resume normality. But once your periods have gone back to normal, it is okay to start to consider to fall pregnant, because our bones are fine. Yeah.
And then the timelines for that would be sort of what you mentioned earlier, that if you haven't conceived within 12 months, then you should potentially be concerned.
So young patients, give them up to 12 months. If there's nothing, if there are no issues of PCOS or whatever, 12 months. Older ones, 35 years, 6 months, 40 years and above immediately.
Okay. Then another question was around, there were quite a few questions around the effect of endometrial ablation on conceiving. Can you maybe give us a bit of comments around that?
Endometrial ablation means that you burn the lining of the womb. The lining of the womb is a sensitive part of the womb that controls, that responds to the hormones from the ovary. So the ovary tell the womb to prepare for pregnancy, and then the womb prepares for pregnancy. If the patient doesn't fall pregnant, then that preparation is lost. It's called menstruation. All right. Now, if you damage that lining, that sensitive lining of the womb, then what is left is tissue, which is not responding to the stimulation from the ovary. So the lining of the womb doesn't become thicker. And therefore, for pregnancy to happen, you need implantation. The embryo has to stick to the womb. That lining has been damaged by ablation. So you have damaged the lining. You've got now scars. Blood doesn't flow through scars nicely. And if you're pregnant, you need to have blood going to the baby, to the placenta. Now you've created a lot of scars there. So blood flow from the mom to the baby doesn't exist. And therefore pregnancy is a challenge. If you do ablation, you probably will not fall pregnant. So don't do ablation if you're not sure. You do ablation if you're absolutely sure that you don't want to fall pregnant. There are other ways of treating heavy menstrual bleeding other than ablation. It should be your last resort if you're still there.
Wow, that's very, very, very insightful. So there's a question that was asked, and I think it's an interesting question just to perhaps discuss. And, when you started in the session, you spoke about how infertility is both a male and a female problem, but there's a lot of stigma around infertility. And the question here is, how can we break the stigma around infertility, especially for people who are not in the healthcare sort of sector, and to ensure that people have a place where they can actually discuss this, because we do understand that it's becoming more and more of a concern.
Yeah, I think it's important for folks to join groups like there's a lot of social groups on fertility. I know IFASA, I know fertility, one from Cape Town. It's a lot of social groups, fertility group of patients who come with patients and talk these things. The psychologists involved, and they help us deal with these particular issues. And also, we need to normalize fertility as just another condition that can be managed. Remember, fertility can be managed. The problem is just access to care and funding for care. It can be managed. State facilities are very, very few, but even in the state sector, they're trying to increase the facilities in various state hospitals so that even the indigent people can afford the services. Stigma is unfortunate. It's everywhere. Even men get stigma, not only ladies. Men, there's a serious problem. The problem with men is we don't talk. We suffer alone. Unlike ladies, we can at least talk and have support groups. Men don't have support groups. It's a big problem. We see it, and there are a lot of male groups as well that are coming up now to try to support men with all sorts of problems.
Okay, no, thank you for that. And another question, which I think also has a lot of stigma attached to it, is around patients who've previously had termination of pregnancy. Does termination of pregnancy affect fertility in the long run?
It's a very good question. I'm glad you raised that question. Previous termination of pregnancy does not affect your future fertility if it was done appropriately in a proper center. Remember, there's probably no patient today who has a child who hasn't had a miscarriage before or a termination of pregnancy before. Remember, I said to you, 70% of baby pregnancies are lost. And the majority of them, you will not even know that you are pregnant. So a termination of pregnancy should not bother you. If you've done one or two before, please don't let that stress you. Your chance of you falling pregnant is like anybody else who hasn't terminated before. It should not be an issue at all. It's the right thing to do. If you have to terminate your pregnancy, terminate it. It is the right thing to do.
Okay. No, thank you for that. And then another question here was around, what are the maternal complications of fertility treatment? So, I mean, obviously, we are hoping that fertility treatment will result in a baby, but are there other things that can potentially happen to a female patient undergoing fertility treatment that they need to be aware about before they undergo that treatment?
Yeah, that's why it's so important that they undergo this clinic in a proper center, because it can be a dangerous process. You can get complications from the treatment because one has to monitor how the eggs are growing, how many eggs are growing. Because there are too many eggs that grow, it can lead to something called hyperstimulation syndrome. And when we have to take out the eggs, one has to be careful because we can injure the intestines, we can injure the bladder. It's a dangerous process. So the doctors have to know what they are doing. And then the pregnancy itself, depending when we transfer, is it fresh transfer, frozen transfer, might have bigger babies. There's all sorts of complications that can happen, and this can be discussed per patient in a fertility clinic, depending on what is your protocol, what is the aim of treatment here. So IVF treatment is a potentially dangerous process that has to be done in a center of excellence.
Okay. And then there's a question here around couples who are of the same sex, so same-sex couples. When it comes to a male same-sex couple, is there a decision around whose sperm is used to fertilize the egg? Is that a conversation that is had, or how would the procedure work in that situation?
Yeah, so the couple would discuss it and decide what they're going to do, whether they use this guy's sperms or the other guy's sperms, or whether we mix the sperms. And then based on the agreement, then we'll do as they propose. We would obviously get a surrogate to carry the baby for them. It's a legal process. We go to court to get permission from the judge to have a surrogate for them. So, but in terms of sperms, we can mix them or so they can decide. It's a discussion that will be held with the couple and the psychologist if necessary.
Okay. And then an interesting question here around, can one be born with infertility? Are there a percentage of patients who are just unable to conceive from the time they're born? And
Yes.
how would they know? Like, when would that be something that you would discover?
You may be born without a womb. So if you're born without a womb, it happens, all right? Or I call it plastic uterus. And then obviously you can't carry your baby, but you've got eggs. So this you can use your eggs and have somebody to be your surrogate, all right?
Mm.
Sometimes you're born without a womb, but you don't have eggs. Then somebody can donate you eggs and then you carry your baby. So you can be born with issues that affect your fertility, but in general, there's something that can be done to ensure that you got a child. There's always something that can be done. And then some patients will have conditions like, let's say, Turner syndrome, where you run out of eggs very quickly. Within the first 10 to 15 years of your life, you've run out of eggs. But if you know the diagnosis before, and we can freeze those eggs before you run out of eggs and do something about it. So yes, you can be born with a condition that will make you infertile, but there is something that can be done to manage that in general.
Okay. One of the other questions is around perimenopause. I think it seems that a lot of women are experiencing perimenopause at younger and younger ages. And the question here is around, if a woman is starting to experience the symptoms of perimenopause, does that mean that they can no longer conceive a child?
So any woman can conceive a child irrespective of the age. The issue is not about whether you can conceive or not. The issue is, can I use your eggs or not your eggs? So if you're in the perimenopause, probably the quality of your eggs has declined to such an extent that you will struggle to fall pregnant with your own eggs. And if you do fall pregnant, there's going to be a high risk of getting a miscarriage or an abnormal baby. So those patients with hot flashes and whatever, they've got few eggs, for them to conceive, it would be advisable that they use donor eggs. So even if you're 50 years old, you can still use donor eggs for you to conceive. So they can conceive, just about whose eggs are we going to use to make you fall pregnant.
Okay. Okay. And one of the things that we discussed slightly before we started the session, which is an interesting question that's come up, is around supplements. And you made a comment, Dr. Biko, that some of these supplements are not helpful. I don't know if you want to just quickly expand a little bit on that around the use of supplements for fertility.
So a lot of our ladies use a lot of supplements because for some reason the ladies take a lot of supplements and take same thing with different names and can be problematic. And the big thing is the older ladies. Now, at the moment, there's nothing that we can do or we can give a patient to make their eggs younger. There's nothing we can do to turn a poor quality egg into a good quality egg. If you look at the supplements, they'll say all these good things that try this one, you're going to make you pregnant, whatever. That's not on. There's no scientific evidence for that. It's just nice to say. There's nothing we can do to make your eggs younger. If you're about 40 years, 43 years, you're going to struggle to fall pregnant with or without supplements. Now, the issue about supplements come from these oxidative stress. People talk about the oxidative stress, whatever. So you want to reduce the oxidative stress. So you take all these nice vitamins and coenzyme Q10 and all that kind of stuff. They are nice, like I said, but in moderation. If you take too much of them, we move the patient from one side, which is oxidative stress, into reductive stress. Both those stress factors are negative to reproduction. So one has to be in moderation. Don't take too much of these antioxidants. In male, we say not more than 3 to 6 months. In female, also you're very careful. But ladies take a lot of stuff where there's no evidence of them working. They call them add-ons in the UK as well. And there's been a big outcry that add-ons, patients spend a lot of money on add-on therapy while there's no evidence of a better outcome. So you take all this spend money for these things, but there is no evidence that you're improving the outcome by taking all these add-ons.
Yeah, I think that's very insightful because these products are obviously marketed to patients quite heavily. And when you're in that place, people are very desperate.
Absolutely. Absolutely.
And then there's a question here around transfers during IVF. So the question is around, internationally, there's sort of a move towards using single embryo transfers. From a SASREG position, how many embryos are sort of recommended to be transferred during an IVF cycle?
So all our SASREG clinics, our guidelines state that we recommend elective single embryo transfer. Twins, we don't recommend it because they've got a lot of problems. But South Africa is a democratic country. Patients have got their rights. And there's also issues of ethics, the issues of autonomy. Now, we would give patients a document that says that we recommend single embryo transfer. It states clearly these are the reasons, the problems with twin pregnancies. Problems to the mother, problems to the baby. And we say, listen, so we tell you this is the problems, we want to put in one. Do you agree or do you want two? And the patients will write down, I hear you, doc, I read this, but I want two. It's my right.
Okay, and you let them decide, and then that's the process. What are the risks with multiple embryo transfers? So what are the potential downsides of doing more than, or transferring more than one embryo at a time?
There's problems to the mother and problems to the baby. To the mother, there's a high risk of hypertension, pregnancy-induced hypertension, high risk of diabetes in pregnancy. Right? There's a big chance you will get cesarean section. There's a high chance of them dying during the pregnancy because it's a high risk pregnancy. To the babies, they're going to be premature babies, high risk of prematurity. And we know that prematurity can lead to, in the long term, cerebral palsy, which means this child will remain a child even in their adulthood. These kids, if it's twins, they get born before time, and therefore they go to ICU. Now, the reason why Discovery is paying for single embryo transfer is because the cost of IVF is cheaper than the cost of a baby in ICU per day. So twin babies go to ICU. They spend a lot of money and time there. They get lung problems in ICU. They get intestinal problems in ICU. So single embryo transfer, one at a time, it is the best outcome for IVF. One single healthy baby at a time, it's the best outcome for IVF instead of two sick babies and a sick.
And then I think we're nearing the end. So I want to close off perhaps with this question. The journey of infertility is one that's very mentally and emotionally taxing. So I guess the question is around, in terms of the psychological support, when a patient is coming in for infertility treatment, what are the recommendations around mental health and psychological support, especially as they're making these very difficult decisions?
Yeah, it's a very important point. It affects both male and female fertility. It affects the family, affects the society. Fertility is a major problem. In our clinic, we don't do IVF treatment unless you've seen our psychologist. We've got an in-house psychologist. And in her presentation in our Congress about 2-3 weeks ago, she reports that I think 3 out of every 5 patients that she sees have depression. So infertility is a major problem. So SASRAC has got a guideline that before we do IVF, our clinic should refer their patients for psychological evaluation. Then the psychologist will say, Dr. Biko, wait, don't start now. Let's first deal with this issue. And also we have to manage expectations. Guys, our system is very inefficient. Chances of falling pregnant are not as great as it looks. So we have to manage our patients that there's a bigger chance of them not falling pregnant than falling pregnant. So if you don't manage those expectations beforehand, the patients are going to crash and go into severe depression. Thus, psychological evaluation before we start is so essential. Some of our patients decline it, and they tend to regret the decisions later on. But we offer it to everyone.
And I think perhaps to close with this question, in this discussion, we've spoken obviously a lot about fertility and how, we can sort of assist couples in conceiving. But I guess the question becomes, if a couple runs out of all options, I think one of the things that we don't discuss are the non-conceiving options. So what are the options? You mentioned surrogacy, but are there any other options for couples who sort of reach the end of the road? And how do you approach those discussions in terms of exploring options beyond just the couple themselves conceiving?
Yeah, so there's a lot of issues. Especially the older girls, we don't just help you because we can. We do a medical checkup, make sure that you will be okay during pregnancy. Sometimes people are not well enough to carry a pregnancy. Then we talk about the options of adoption, which is, and the company is apparently it's very difficult and very laborious to go through an adoption process that you don't have a choice. They give you what they have. So it's issues that, and then there's why also the psychologists and social work are so important, because as doctors, we don't have much information about the aspects of adoption. Then our team from psychology will then take over and handle that aspect of the case. But we put everything on deck to the patient. So these are the options. Most of our patients prefer to rather try with somebody else's egg than to do an adoption. But where there's an option, if she's too sick to fall pregnant, then we say either surrogacy or adoption.
Okay. All right. Dr. Biko, thank you so much. This has been such an insightful discussion. We really appreciate you giving us your time. To everyone who has joined in, please also remember that you are welcome to download the Netcare app. Through the Netcare app, you can find a lot more healthcare information, but please do make sure that you're able to download this app, because it will help you to get in touch with us. If you want to book doctor appointments, anything else, you're welcome to do it through that. I've just put that link in the chat. But thank you guys so much. Thank you to the audience for your questions, the questions that came through beforehand and even tonight. Thank you for everyone who joined, and please stay tuned to our social pages. We're going to be having these talks every month. So please stay tuned for the next talk. And yeah, we thank you, Dr. Biko. We can't say thank you enough. This was a really insightful presentation. Thank you for your time.
Thank you very much, ladies and gentlemen. Thanks, Doc. Bye.
Thank you. Bye.